Well, my chat box is open, so you guys can, I mean, not my WhatsApp chat, my my Zoom chat is open. So anything, please post on the Zoom chat as we are talking along, and I'll read out the question. All right. So now, for those of you who got a date, fantastic, congratulations. But I also know that adrenaline will be very high right now, and panic and anxiety. So I'll try my very best to reduce that anxiety level, in you. All right. Now, so in this exam itself, there's quite a number of things, and a lot of you are might be very fresh from AMC 1. Let me tell you, AMC 1 is very, very different from AMC 2. I will explain that in a little bit more detail. But here, in AMC 2, what we have is it's a clinical exam at the end of the day. It's a talking exam. You have 5 to 6 different core subjects. So we have medicine surgery, we have pediatrics, ops and gynae, psych, physical examination, which is a very big part of it, very exciting part of it, and counseling. Now, when it comes to counseling stations, it comes between all of them as well. So you can have med-surg counseling, peds counseling, OBG counseling, and psych counseling. It comes over everywhere. But the reason why I've separated is because the amount of content and knowledge that you need to have for counseling is far more greater, okay, compared to your med-surg and your smaller stations. And even when we start talking about how many stations do I have, what is the breakdown? Let me just explain to you a little bit about the scoring system first. All right. And please let me know if I speak very fast. I have a tendency to fly. All right. I will try to slow down though. Now, I will also be talking about the scoring system today. I will be telling you guys about what is this predominant assessment area that everybody keeps talking about, and what are all the different domains that AMC is testing us in the exam, and what do these domains mean, and how do we score in the various domains. And I think we had a question just now asking me, love, will I know what is the predominant assessment area? Will I know what domains I'm tested on in the exam? Well, if you had at least 5 minutes to read your question, I would say you can find out what the domain is. But because you only have 2 minutes and you don't even get a complete 2 minutes of reading the question, it's very, very difficult for you to actually go and interpret and analyze on what is the domain area. You don't have time to actually do that in the station. And the reason why we also struggle to do that once the recalls come out is that a lot of the phrasing, a lot of the structure becomes very different when the recalls give us the questions. Therefore, we can figure out, but it's very hard to nail down the exact domain until the result script comes up. All right. I'll also be showing you guys sample results because I think it's very important to know how you are scored and what are the exact rules of this AMC game before you even play the game, right? It's very simple. You don't know the rules, it's very hard to score. Now, the other thing that we'll be discussing about are the resources. AMC Handbook is a fantastic resource. I know a lot of my AMC 1 doctors will be like, oh, love AMC 1, the handbook was very useless. Well, it's still very useful in terms of knowledge. I would never say anything is useless, but AMC Handbook is very, very, very extra useful when it comes to AMC 2. So I really, really hope that all of you guys can actually start using the AMC Clinical Handbook as soon as you have gotten a date. Start reading. I know it's very dry. I know it's very difficult, but I will break it down on how to make it a little bit easier for you and how to understand how to use the book. I think we are afraid to use the book because we don't understand how to use it. So let me try to break it down and see if that works for you guys. And also, I do have a couple of videos on handbook cases on YouTube as well. I will share the link later. So if you think you're a bit lost, you need a little bit more guide, you can go watch the videos and you will guide you through on how to use the handbook and how to start discussions for that. All right. John Woodtuck, I know everyone's very familiar, and Telly O'Connor, I will show a couple of pictures for that one later on. All right. Now, so for those of you who do not know what exactly is AMC2, so I know my audience today will be both new doctors for AMC2 and also my recent doctors. So, well, in AMC2 in general, it's an OSCE exam. So we usually call it an oral, structural, clinical exam, right? To test your knowledge and your skills. So previously in 2024, or rather in 2024-ish, 2023, when COVID was here, it was an online exam. Now we still have a couple of online exams available for rural doctors, rural GPs, but mainly 90%, 95% of it is usually face-to-face in Melbourne now. All right, and people are very scared about the pass rate. So yes, I'm not going to be very fancy about it, but yes, the passing rate is not super high. But then it has been increasing slightly. I do see more passes in recent times. And just because the passing rate is not super high, do not get overwhelmed by it because people still do pass the exam. All you need is just the right approach, the right understanding of it, and of course, a teeny bit of luck. okay, that plays a part in your exam. And I'm very sure that a lot of doctors, I mean, we all studied for 6 7 years, right? And then we did specialization, and then now you're coming for AMC too. So you have a lot of knowledge. But the problem is that a lot of my specialist doctors will tell me that, oh, love, I end up failing only my specialist stations. I have OBGYN specialists who only failed OBGYN stations and passed everything else. So because we tend to bring our specialist mindset when we go for the exam, but when you're going for this exam, you need to understand that you're only expected to perform at your junior medical doctor, JMO, and house officer level PGY1, very low level level of your exam. And every particular station that you get, you will be able to solve it. You will be able to figure out what's going on. Never in any of your stations would you need to say that I need a supervisor to come and help me in my station. Okay, most of it, in fact 99% of your stations can be handled by you. So the minute you start telling the examiner that, oh, I'm going to involve my supervisor, the examiner will know you actually don't know what you're doing, and you're confused, and you're not safe, and you're not confident about what you're doing. You give that impression to the examiner. So try to avoid that when you are speaking in your management aspect of things in your stations. All right, why is my slide not moving now? Okay, here. All right. Now the exam has 16 stations for those of you who do not know, and there's 4 rest stations, total of 20 stations. Now 14 of the stations will be scored, which means you have 2 pilot stations in your exam. Will you know your pilot stations? No, you will never know which are your pilot stations until your result script comes out and then you're like, that was the pilot station. And everybody will tell me, oh, love, I did very well in my pilot station. Okay, I also always told myself that, oh man, if only the pilot station was scored, I would have done way better. Okay, that's a very typical human mindset to do. So, okay, that's something for you guys to know about. And in every station, so in the previous time, you needed 10, I think from March last year. I can't remember, I think March, September last year. You needed 10 stations to pass the exam. Now you only need 9 stations to pass the exam. So people might think that, oh, does this mean that the exam is getting easier? That's why they're giving like 10 stations, or is it getting harder? But I can tell you the pattern that we have seen so far in the past 1.5 years or 2 years is that the task is changing. So the core concept is still the same, but your task is becoming a little bit more specific, a little bit more tricky. It requires you to understand a bit more on the pathophysiology side or the concepts that you're talking about. So for example, in recent times, just like in October, I think, they asked a question on the phases of bereavement. They never really asked that question before, but they asked the phases of bereavement. So in the exam wants you to really understand, do you know what is anniversary grief? Do you really know what is prolonged grief disorder? Do you really know how depression actually works? How the duration actually works? So if you really understand the concepts and don't just memorize them, this exam will be way easier for you. And this exam is also starting to expect us to be very flexible about things. So I have a lot of doctors, or in fact for me as well, my personal experience was that every time when I used to study for the exam, when I studied my headache, right? I used to headache physical examination. I used to just do, okay, headache PE equals to cranial nerves. That's what I always told myself, right? And then when I went to the exam, I realized that at the bottom, there's this very small line that said, do not perform any cranial nerve examinations. And I didn't read this line before I went into my station. So I happily go in and I'm like, oh, well, hi, my name is Love. I'm going to do this. I'm going to do the cranial examination for you. And then the examiner now comes in and says, read your task. So I read my task and I read my entire stem. I stare at it. And I'm like, oh, crap, I'm not supposed to do any cranial nerves, but it's the only thing I've planned in my brain. So the AMC is starting to now break your structure, break you a little bit in the normal things that you used to do. But the only thing is, don't panic. I know it's very, very easy to say. It's super easy to say, but it's very hard when you are there. But prepare yourselves for flexibility. They just want to see how flexible you are in the exam. And when you are able to have a little bit of anxiety, or they throw you off charts, but you actually come back more confident, your scores will automatically go up in your station. That is something to remember. And also in these days, they're changing their task names, right? They're asking you for causes of the condition. They are asking you for example, asking you for implications, complications, consequences. So it's no longer just history, management, all of that. Even when it comes to substance abuse, they're asking you for assess the abuse, assess the tolerance, assess the motivation. So if you do not know what is tolerance question, you do not know what is motivation question, it'll be a bit difficult for you. So therefore, when you're studying, try to make sure you understand, why am I asking this question? so you can edit accordingly. Okay, Farida, you asked a question. What do we do in the case of headache P if you don't retain nails? Yeah, that was my exact problem in the exam. But it was fun because in the end I ended up doing look, feel, move of the head. I did palpation of the entire head, and then I did ENT. I did otoscope, I did fundoscope, I did neck stiffness, I did basically you do everything, right? Just that now you frame it differently. So for example, in cranial nerves, when you talk about headache, cranial nerves number 2, right? You'll be doing your CN2 for your 7 different eye examinations. But now all you gotta say is, oh, I'm going to do my fundoscopy. I'm going to check for visual acuity. So the way you frame it is different. So the task is actually asking the same thing you are doing, just phrasing. So instead of saying, oh, I'm going to check for cranial nerve number 8 for vestibular cochlea, now you go for, oh, I'm going to do a ear examination. I'm going to do an otoscope. Same thing, different phrasing. So don't panic. Everything goes the same. So they're just trying to play with you and play with the words. That's all in this exam. And they're trying to do this way more often, everybody. So you got to be a little bit more sharper when you read your task, which is why I always tell you, please expose yourselves to the handbook, because in the handbook task, you realize they're so specific and they catch you off guard. All right. And because we are all reading recalls kind of questions, the phrasing is not the exact same as how the AMC would have phrased it. So what you see in the recall is very, very different from what you actually would see in the exam. All right. So that's something I want you guys to take note. Okay. Now, why am I saying the same thing again? Here. Okay. So a lot of you guys have been asking me how many stations might we have left, right? MedSearch, remember, is always your greatest number of stations because MedSearch is very important. Please focus on MedSearch stations. MedSearch usually is 5 to 6 cases. PEDS, ONG, Psych, usually not as many as compared to the rest, only about 2 to 3 on average. Physical examination, minimum you have 3. So far, maximum I've seen is 5. It happened in September 2024. There was one day that had 5 cases of PE. And then this year, again, somewhere there was 5 PE on one of the days, in March, if I'm not wrong. So I felt so bad for candidates sitting for the exam on those days. But if your physical examination is strong, nothing to worry about. All right. And then one more thing, pediatrics, ONG, and psych, right? These are stations which are very easy to pass. The reason is because the examiners know, or AMC itself knows, that we are not specialists. They know that we are all just going at HMO, general internal medicine level standard that we are going in for. So as long pediatrics, ONG, and psychiatry, you are able to give or show a good list of differentials within your history taking, if you're able to rule out your red flags and show the examiner that you actually did think about a scope of things, you should be able to clear your stations. That is the good thing about PEDS, ONG, and psych. All right, that's all you need to do. Very, very easy to clear. And the more easier thing about psychiatry is many people are very afraid of psychiatry. Psychiatry is my favorite. One reason is because psychiatry only has a limited number of diagnoses. And that's it. Depression, you only got to find for low mood and find the 9 symptoms equals to diagnose with depression if they're having it in low mood for 2 weeks. So very, very easy. Psych is so limited. Okay, only about 40 diagnoses up there for you. And they're only like a couple of clusters. So it's so easy to revise your psychiatry. So start living the things that you don't like. It will be a bit easier to start studying for your exam. Dr. Adira, well, the session will be available on YouTube. Okay. Once I finish, I will send the slides to you guys, and I'll also put up the video for you guys on YouTube. Yeah. Okay. And now, with regards to the task, any questions so far with the type of stations you are getting? If not, I'm going to spend time talking a little bit more about the task and the domains in the exam. Any questions, just post in the chat box. Yeah, I'll have a look. Now, have a little read on this slide. These are all the different tasks that you have in AMC. Okay. Definitely, these tasks have all been evolving in the exam. But before I dive into tapping on the different tasks and what's out there, let me share a little bit more about this whole prompt timer thing that's been going on. And many people have been confused about this prompt timer and panicking about it. Now, every station has a prompt timer. There's one thing that you need to know. However, every station can have a different prompt timer. So once you go inside, or when you're reading the STEM or the task, it will tell you, take history for no more than 4 minutes. This station has a 4-minute prompt timer. So when you are in the room, the bell will ring at your 4th minute mark. You have a ding, a bell will ring. right? And when the bell rings, the examiner will then tell you, this is your 4-minute prompt timer. Now, prompt timer just means that, okay, it is time for me to move on to my next task. I only have 4 minutes left in my station. That's all prompt timer means. However, if the task tells you, or the STEM rather tells you, take history for no more than 4 minutes. Now, in this case, once your bell rings, you are not allowed to ask any more history questions. You need to immediately move on to your next task. Okay, so I mean, if it's a prompt timer, you can ask 1 or 2 more questions before you move on to your next task. But if it says no more than 6 minutes or 4 minutes, then you got to immediately move on to your next task in the exam. Okay, there's the prompt timer concept. And outside your room, you get 2 minutes. Inside the room, you get 8 minutes. But as I've always said, you never get a complete 2 minutes every time except the first station. I'll explain that a little bit more with my little picture that I have at the end of the slides. And I'll explain why you actually don't get 2 minutes. And it's so disappointing that you don't get 2 minutes. Right? Now, history taking, very, very easy. Okay, not very, very easy. It's doable as long as if you have a structure. Structure for OBG, Peds, Psych, and Med Search are a little bit more different. So please study them and make sure you know what your structures are when you're doing the exam. And a lot of doctors like to ask me about differentials, right? Now, differentials can be a task on its own. But if there's no differentials question being asked in your task, all your differentials actually need to be in your history. So when you're asking me a question or asking the role player a question, the examiner should know what differential are you trying to rule out. So for example, any random, if you ask a question of, let's say, is there any changes to your weather preferences? We immediately know that you are trying to rule out thyroid problems. Or if you ask me, oh, has your heart been racing recently? I immediately know that you're talking about palpitations as a symptom. Or maybe you're thinking about atrial fibrillation, right? So where you ask your question and what question you ask will let the examiner know on what differential you're trying to rule out. So that's why a lot of candidates tell me, oh, love, the station did not ask me for differentials, but then my dominant area is differentials and I failed the exam. And I was like, yeah, that's because you didn't ask anything in the history. So my thing is how can you be a good clinician if you do not rule out differentials within your history taking? Your job is not to only confirm the diagnosis. Your job as a clinician is to rule out all the other differentials, make sure your patient is not having any other kind of red flags, and then complete your examination looking for any kind of complications your patient might be having, and then wrap off your station. That is how a good, ideal, full scoring 7/7 history taking will be. And I have seen doctors getting 7/7. So it is not difficult. I mean, it is a bit tricky, it is a bit difficult, but it's not impossible to get a 7/7 on history taking if you are very holistic about things and you are flexible and you adjust accordingly in your stations. Right? Now, the other task that people talk about will be the PIFI task, where it's called physical examination from examiner. I do have a session on YouTube for PIFI specifically because I know it's something that many of us were struggling with. So you can watch that session on YouTube to just get a little kickstart on how PIFI stations are. And PIFI stations, usually it's called, you have to do it very structured. And doctors who are strong in physical examination stations automatically become strong in PIFI asking tasks. They kind of correlate to each other a little bit. And I know your strengths and weaknesses based on watching you do a particular station. So in PIFI task, usually you need to do your hemodynamic stability if needed. You would go for your general appearance. You would then go for vital signs, BMI or growth charts, depending if it's a med search case, adult, or whether it's a pediatric case. And then you take a very systemic approach. So for those of you who do not know too much about PIFI and who are new, please watch that YouTube video because I think I spent like an hour talking about PIFI in that particular video. All right. And here I want to spend time talking about giving you a very good overview, not a very detailed, deep explanation. So at least after today, when you go and plan what you're going to study, you know how to study at least for the next 1 to 2 weeks and how to plan towards your exam. All right. So we spoke a little bit about diagnosis and differentials. Now, a lot of doctors ask me, love, how important is it to clinch the diagnosis and to nail the diagnosis? Well, the truth is this. The AMC is looking at your thought process on how you get to the diagnosis. You getting the diagnosis is a bonus, it's a value add, but the process is more important. So for example, let me put you this station here. For example, in a rectal bleeding case, okay? In a patient who comes to you with rectal bleeding, right? Your biggest red flag, of course, would be cancer and mesenteric ischemia. These are your two biggest red flags in a patient who comes to you with rectal bleeding. So in your question, in your history taking, so for example, let's say you do your history of presenting complaint very well. You ask about the color, the volume, the odor of the bleeding. When did it start? Was it gradual? Was it sudden? Is it the first time? Is it worsening? Does it happen all the time? Ask all of your questions, and then now you go for, I am going to ask for associated symptoms with bleeding. I want to see how bad and how severe my patient might be bleeding. And so you ask me a question, say that, oh, are you having any kind of palpitations? Are you having any kind of dizziness? So now if you put palpitations and dizziness together, it shows the examiner that you are thinking of the severity of the bleed, right? Is my patient clinically hemodynamically stable? That's what it means. However, if you ask, are you having any tummy pain? Are you having any palpitations? If you put palpitations with tummy pain, now it's signaling to the examiner that, oh, this doctor is thinking of mesenteric ischemia, red flag, because of how mesenteric ischemia is very highly comes together with atrial fibrillation. So the point is this, where you put your question will change on the process the examiner gets on how you are thinking. So it's very, very important. And now for those of you who are starting your exam, please don't just memorize structures blindly. Understand why you are putting the question. Always go like, will the examiner understand what differential I am trying to rule out based on these questions? It's just not memorize and vomit anymore. All right, you need to adjust accordingly in your exams. So diagnosis you get correct or wrong is not the most important thing. Your process to getting it is important. And of course, if you don't get the exact accurate diagnosis, but your process was very, very beautiful and you got that, but then in your differentials, your top 5 or top 3, you told me your diagnosis, very easy, you will clear the station, which is why in many of the exams you've heard doctors say, oh, I didn't get the diagnosis, but I passed the station. That's because their thought process was very clearly explained when they were doing the history taking. There's one thing you need to ponder about when you're doing your stations. And of course, many of us have role play partners. Start finding your role play partners, but make sure you find role play partners who are at your level, at your standard. Okay, I know it's a bit mean to say this, but that's the truth. Some role play partners are going to pull you a little bit down and some will make you stronger. So make sure you're not pulling someone else down as well. So find someone very similar to your standard, very similar date as well. That'll be easier for you to work forward with. And this is only do what's best for you in the exam, all right? And be okay with having more than one role play partner. And one more thing is that record yourself. As much as role play partners are out there, you must understand you only will do as well or as much as your role player partner knows. If they are unaware of certain things, you would never be able to correct yourself in that. And you are also your best critic. So record yourself once in a while. Even audio recording is fine. Record yourselves, play back and listen. Am I clear? Am I smooth enough? Am I articulating myself very well? Do I actually understand the question, or did my role player partner just, you know how role players, we like to be nice to each other, right? I know a lot of doctors, because we end up being strangers to each other sometimes. We are so nice to each other, like, oh, you did awesomely well. And you're like, oh, was it really awesome? But you still say the patient, your friend did very awesomely well. So I'm not saying that it's not a nice thing to do, but just remember that your role player might be a little bit more kinder to you. You are your best critic. So please record, hear yourselves, and criticize yourselves more than your role player partner does. All right. Now, the other kind of task I want to talk about was your approach to patient. Where is that? Oh, I didn't have that yet. Do I have that yet? Sorry, approach to patient task. Now, in the approach to patient task is one of the domains as well. I'll come to that later. But any questions with all the different tasks that's out there? Okay, PE, you guys should be okay with that. I mean, it's physical examination, very face-to-face, have to carry it out. With regards to management, now with regards to management, there is a structure to do management. I know there are many structures out there, but the most important thing is that management always starts with investigations first. Investigations to confirm your diagnosis, to rule out the red flags that you could not rule out even with a history-taking question. Okay, so for example, what do I mean by that? If a patient comes to you with chest pain, right, and then you do a history taking, you realize that patient is having GERD, and good, it's like, okay, I mean, it's good, right? You just send back home. You can do you give your PPIs and all of that. You can do your HP, bacteria testing, all of that. But then you have to do an ECG because chest pain is masked as MI and so many of your red flags. Therefore, you would 100% have to do an ECG in your station. If you don't do an ECG, it might lead to failure in your station because you missed a possibility of myocardial infarction, and that is very, very critical. So please be aware when it comes to management, you do investigations to confirm your diagnosis and to rule out red flags and conditions you were not able to do in history taking. Okay. Now, counseling stations usually comes up to about 6 minutes or takes up the entire whole 8 minutes. Every counseling station is a little bit different, but then Breaking Bad News has an overall structure to it. When you do counseling cases, of course, you will do your headings, you will do your basically it's management, but it's a little bit more elaborate management, not just like a straightforward 1 minute or 2 minute management explanation. So you need to have content. If you have no content for counseling stations, very, very difficult to stare for 8 minutes as your role player. So please study counseling. And the good thing about counseling is that it also helps you understanding content. And for those of you guys who are doing armor's course for counseling, his counseling stations are really, really very good, and he gives a lot of information about the counseling stations. But please also go and read on your own, add on your own. I've always told doctors that when you go for the exam, 40 candidates every day, right? 20 in the morning, 20 in the afternoon. And out of these 40 candidates, 30 of them would have gone for one particular organization to learn their course from, another 10 or another 5 from somewhere else, which means at the end of the day, everyone is just saying the same thing, just a little bit with their style. You need to add your own things, add your own knowledge, be a little bit more different from the person behind you and the person in front of you. You cannot just go there and repeat the entire same thing. The examiners are going to get bored, man. So go and find things which makes you a little bit more unique. If you do watch my YouTube videos, especially the cases that I've done so far, I always try to give you one or two fun, cool facts in the middle of the cases. So for example, when I did type 1 diabetes with you guys, I did type 1 diabetes with the doctors before. And I told you guys Nick Jonas. I don't know if you guys know Nick Jonas, but Nick Jonas is a Hollywood actor. He's a musician. He has good music. He is a part of the Jonas Brothers. He has type 1 DM. And he has shown how people with type 1 DM can be so successful in life and be happy and have kids and travel the world. So every time parents are like, oh my God, my child has type 1 DM, is my child's life over? You got to go, no, look at the examples of people who are out there. So talk about these things in your station. Go find 1, 2 cool facts in your stations, all right? It will take time, it's additional effort, but then the examiner will remember you for that. And if you're sitting behind that global score rating of 3 or 4, should I pass this candidate? They were good, but then they were not good enough. They didn't impress me. Now, these extra things will make sure you sit on that 4 and you pass your station. So it's not just about giving you clinical things, it's about being a little bit more cool, a little bit more extra so you can clear your stations easily. Don't give the examiner doubt to be like, should I put this person at a 3 or 4? Okay, it should be a very good, clear cut 4, 5, 6, 7. That's what we're aiming for in the exam. All right. Just a little quote. I'm sure by now you guys know I'm a very quotey person, very life values person. Okay. Now, with regards to the domains that I want to speak about in this exam, so these are the domains that you are scored upon. I will show you a couple of sample result script. We'll try to understand how the results are being marked and how the stations are being marked. All right. Now, with approach to patient, one thing, guys, approach to patient, very, very easy to score. As long you are nice, you are calm, you are chill, you smile once in a while, approach to patient, you will pass very, very easily. So don't bother so much on that. And I think most of the IMGs are quite kind, right? History taking, I've spoken very much more about that. I think most of it I've covered. I'm just going to tap a little bit more on choice of investigations and interpretation. Okay, I'm going to show you a little example for what do they mean by choice and interpretation of investigations and how they actually can mark you down if you give like extra stuff. Okay, I'm going to use a recent recall or a handbook case rather, I think I used. Can't remember. Okay, have a little read on this station and then I'll show you a little bit on the investigations that you need for this case. Okay, so it's vaginal bleeding after 8 weeks of amenorrhea. Okay, so it's called first trimester, most likely first trimester bleeding. And in first trimester bleeding, now put in the chat box for me, what is your red flag for first trimester bleeding? Red flags to look out for. Red flags in first trimester bleeding. I know you guys just started studying for AMC too. I know I'm pushing your brains a little bit. But red flags, put in the chat box. Yes, various type of abortions in the chat box. Various type of miscarriages, fantastic. I'm looking for something else. I'm looking for something else. Ectopic, fantastic. Super big red flag. Any women who is pregnant comes to you with bleeding, comes to you with abdominal pain, ectopic, number one concern. Now, there's one more that is important to look out for in first trimester. Not abortions. Yes, PID hematoma, yes, you can say. Molar pregnancy. Molar pregnancy is another one that happens in your first trimester. Also, HOPC presenting complaint does come with bleeding. All right, so these are things you need to start thinking of. So when you start practicing your cases henceforth, everybody, look at a station, just read it first. Now, what are my differentials? Vomit it out, discuss it out with your friend, or just say it out of your mouth and be like, do I understand what the task is asking of me? All right. Now, let me show you a little bit on the investigations here. This is what the exams, the handbook says. In this station, it is very, very important for you to first confirm pregnancy. So yes, the lady told you that she might have been pregnant, right? But if you go back to the STEM a little bit, it says she believes she's pregnant because she's been trying to conceive. Now, until you in your clinic have done beta HCG, serum beta HCG, you cannot confirm pregnancy. Yes, it's great to tell the patient, oh, I understand you, but do not go get her very hoped up, get her very high about it. And you got to do your own beta HCG first. And you don't got to do UDT. Now, urine pressure, UPT. So urine pregnancy tests, there are also false positives. So therefore, until you do a proper beta HCG, then you confirm pregnancy, and then you warn her of all your complications that might be there in your station. So let's go back here. Under investigations, we notice here, confirm pregnancy, got to do that. You got to do an ultrasound to see if she's even pregnant or what exactly is going on. And then you have to also talk to her about blood grouping in your history taking, and also ask about her blood group and the anti-D concept when it comes down to the investigations. Your direct Coombs and indirect Coombs testing needs to be done in this particular station. If you don't do any of this, it's a critical error and it might lead failure to your station. That's one thing to take note. So if you read here in the commentary, it shows that when taking history, right, not being focused enough on the actual problems. These are common problems that candidates faced. So this is how you actually use your handbook. Look at what the critical errors are and then read the commentary. I know it can be boring, but let me tell you, the handbook is really, really, really gold, to be very honest with you. It's a very golden tool that everybody has. Now, we are waiting for the new version. Hopefully, AMC has a new version of handbook. Now, here when you're reading this one, if you realize that, you see, you are supposed to be focused on the actual problem. So spend time with the bleeding. Spend time on the severity of the bleed. Spend time with checking if the os open, closed in your physical examination. All of this needs to be done, right? And then ask a little bit more about the pregnancy and move on after that. A lot of candidates in this case, they end up spending a lot of time with the CCVOB, the color, content, volume, odor in the station, and then they just forget about the fact that this lady might be pregnant. There might be an entity problem. So very high failure rate station in this case. All right. Should we mention DD of cirrhosis if no clinical findings? Will it then? Yes. If there's no clinical findings, no counseling being asked to you, you don't have to. Okay? You don't have to. And if no differential is being asked for you in your station, please do not go and talk about differentials in your task. Differentials is a totally different task in your exam. And the reason why you have a differentials task in your exam is because the examiner wants to see if you are able to rank your differentials in a prioritized manner. So if you actually read the tips from examiners paper that they actually release on the AMC Clinicals website, they actually indicate that differentials, they really want you to know the ranking of it. Like, how are we supposed to, what is more problem, or what is the bigger problem in this case? So for example, let's take another case. In a lady who's having amenorrhea, let's have a 23-year-old, okay, let's keep this age, 23-year-old lady with amenorrhea. Your more common problems in a person of why a young girl would have amenorrhea means, not having periods for a long period of time, would be maybe because she's stressed. Maybe there's some kind of eating disorder that's going on. Maybe her BMI is low. Maybe she's exercising. Maybe she's having thyroid problems. Maybe she's having PCOS. Now, all of this are more relevant in a 23-year-old girl. But if you go and tell me my differential diagnosis is premature ovarian failure, menopause, the examiner is going to be like, this doctor doesn't understand the age range and how profiling happens. So please make sure you are working on prioritizing and ranking your differentials if a differential task is written for you. So it's just not about vomiting everything you know. It's about ranking. So rank the first 3 to 5. Make sure it makes sense to you. And then you can vomit the rest after that. That's fine. But make sure, you don't rank it too weirdly as well. So even when it comes to hearing loss, if you've done the case, you know that it's a conductive hearing loss case. So all the differentials you give first should be conductive hearing loss. After you've exhausted your list of conductive hearing loss, then you move on to sensorineural hearing loss differentials. I hope you guys are understanding what I mean by prioritized selection of differentials. This is what they're expecting out of you under your differentials task. So many of you guys do differentials, you vomit it, which is why your scores are still standing at 3 or 4. But those who give a very perfect, beautiful ranked ones, they are getting their 6 and 7s. Okay, and please do not just aim to pass 9 stations. Do not just aim to get 4 in every station. You aim higher, you fall in the clouds. That's it. Aim for the stars, fall in the clouds. A lot of you guys are just aiming for 9. Please push yourselves, aim a little bit more higher, all right? That's one thing you can do. I think that thing really helps with boosting the brains a little bit. And I've seen those doctors who aim for 13 and 14 end up getting 12 and 11, and I'm like, that's good. It's because you scored very high. And those who aim for 9, sometimes they fall a little bit short. They get their 8, and it's so painful to see doctors go through this journey and then fall into an 8 because I know how hard they've been working. Yeah. Okay. Let me explain a little bit more on the domain scoring, right? Because I know it can get a bit more complex when you're new to this. So every domain that I've said so far, you can get a maximum of 7 points in every domain. Okay, 4 to pass, 7. However, just because you passed most of the domains, or even if you passed all the domains, if the examiner does not feel safe, the examiner feels like, something is missing about this doctor. I don't feel safe. You will not pass the station overall. The examiner can still fail you and give you a fail for global rating. Your final score depends on the global rating of the station, which is why this exam, we say it does tend to be a little bit more subjective than an objective, but that's how it works. And very obviously, if you and I are the examiner, we want to feel safe with whoever's there. We want to make sure the doctor feels safe. The doctor is very kind, and I love them. I want to have them as my colleague, right? I want to work with them. That's why I passed them. I can't wait to work with them. So keep that mindset in line and then start working towards knowing that it's just not about clinical things and vomiting structure. It's more than just that. Okay, now let me show you a couple of result scripts out here so you guys will understand a little bit better. So this is how your result script will look like. So they will tell you the predominant assessment area. So in this particular case, it's management, counseling and education. It was a health review. And if you look at this particular candidate, approach to patient was skyrocket, 7/7. So as long as you are kind, you are nice, you're wonderful, you can very easily get a 7/7 on your scoring, right? In this case, PDA was management, therefore candidate got a 6. So overall, it was very easy to score. Okay, so in this place, you can't really see. Here's where the global scoring will be seen. So here's the global score. And this candidate got a 6 for this station. So this candidate got a 6/7 for this station. Now, these are the happy ones. I'm going to show you a little bit sad ones after this. Okay, we need to know what is happy. We need to know what is sad. And what is good and what is not good. Now, take a look at this one. This one is again, a management case. It's abdominal pain. Let me see if I can remember the case. This one was it's been a while since of course, I've gotten this from all my doctors with, of course, their consent and permission to share and show you guys. If I'm not wrong, this was a ectopic pregnancy case, if I am not wrong, if I remember this very well. So an ectopic pregnancy. So if you notice in this case, everything was actually done quite well. This candidate passed investigations, passed DDDDX, also passed approach. In fact, approach was quite strong, to be honest. But then something faltered in the management. Is it because there was a critical error there? Most likely. Maybe antibiotics was not mentioned. Maybe it was a sepsis case. Maybe red flags was not mentioned in this particular case. Maybe investigations was forgotten to be added on top of the interpretation that was already been done. Maybe there was no short term. Maybe there was no long term. So if management is your PDA, which unfortunately you won't be able to identify in your station, Therefore, whenever you have a management task, you need to dedicate at least 2 minutes to your management task. Start from investigations, go for pharmacological, non-pharmacological, short-term, long-term, depending which approach works better in that particular case. Wrap off your station with red flags first. And then after that, you talk about reading materials and reassuring your patient. You need to understand one thing. You not telling me about red flags in your station will reduce your clinical marks, will reduce your marks under management plan. But you not telling me or you not reassuring me or giving me reading materials is not a very big deal, because most to most your approach to patient score goes a little bit down. But then the examiner has had 8 whole minutes to figure out your approach to patient. Do you think your approach will go down just because you didn't reassure the patient, just because you did not give reading materials? It definitely won't. There is so much more core to it to judge you based on the approach to patient. So please give your red flags first and then start reassuring them and giving reading materials. In fact, in my exam, I never once gave reading materials. I never once talked about supervisor. These are all very extra things that you don't need in your exam. These are just, well, if it's not going to help you pass or fail. It's going to be extra, maybe slightly higher scoring, but it won't determine pass or fail. That's the thing about reading materials. So please, I know a lot of doctors spend time finding out, oh, I'm going to give you this from the Victoria website. I'm going to give you this from this website. Please use your brain space for something else, not just for remembering where the reading material comes from. Okay, this is another result script. This one, let me see if I can remember the case. This one was a SOB case. Again, it was management. So if you notice in this case, only management was down, right? Everything else was quite decently done, but candidates still failed the station. Okay, I'll show you other stations. Now this one is this is how your physical examination stations will look like. So your PE stations, you'll be marked for your choice and technique. Okay, how you sequence your entire physical exam. How accurate you are is also very important. A lot of us, I think, we're not practicing PE enough. Accuracy is way more important than just knowing how something is done. So please practice. Please also know how to talk to the examiner and talk to the patient at the same time. It is not easy, I would say, because you need to keep switching between examiner and patient. However, with practice, it is doable. So a lot of candidates do struggle with that. My structure or my idea suggestion for that is that whenever you're talking to the examiner, go, examiner, I'm looking for, examiner, on general appearance, I'm seeing, call him out. If you're talking to your patient, Jonathan, call your patient's name out. That's how you will get the attention of examiner and your patient. Your brain also knows, who am I talking to? When you're talking to examiner, you're a little bit more medical jargon is okay. Talking to patient cannot have medical jargon. Have to explain back to layman and patient way of communicating. So please note that difference. Now this is another scoring. This is for diagnostic formulation. Let me see if I remember this case. So this one, the PDA of examination, this hand problem, it was a cubital tunnel syndrome case. Cubital tunnel syndrome, the case came with tingling and numbness in the hand. Okay, that was a complaint of your first case. This vaginal bleeding case, it was very similar to the case that I showed you just now, but if I'm not wrong, it was an incomplete miscarriage case. Yes, Anna, correct. Management is investigations first, pharma, non-pharma, short-term, long-term, then red flags. But the thing about management is this. Within short-term, you have a particular type of pharma, non-pharma. Within long-term, you have a particular type of pharma and non-pharma. So see which one works according to your particular station. And in psychiatry, non-pharmacological comes up first, then pharmacological comes after that. Here's one more thing. A key domain of 0 will be given if the station is not assessed. So for example, you run out of time in your station. You were not able to even reach management. You automatically get a 0 in that domain. You automatically will fail that station. So please make sure you complete all your tasks. I know a lot of doctors were asking me a little bit about time management issues in the station. Let me finish the result script and then I'll talk about time management. This is the last one I wanted to show you. The reason why I wanted to show you this was because even if, you see, the predominant assessment area here was history taking. Candidate did very well, got a 5, not even a 4, got a 5. But then, choice and technique of some examination was missing. And you see the diagnosis and differentials weren't powerful enough. Therefore, candidate failed the station. So just because you pass PDA does not mean that you will pass your entire station. So I would say don't spend so much time in your station trying to figure out which is the PDA. Go in there, figure out a structure, be prepared to be flexible in your station. Now, about time management. Now, with regards to time management in the exam, one thing to understand is this. Every station has been piloted before. Every station has been there for a couple of years. They've always been checked before they go in as a complete squad station. Therefore, every station can be finished in 8 minutes. There is no station you won't be able to finish in 8 minutes. Now it just depends on how fast you speak, how accurate you speak, and whether you know what is important in each station to highlight about. And of course, hope that we don't miss any of the red flags in your station. So time management should not be a problem. For those of you who are starting out now, I would say keep to 8 minutes. Slowly cut yourself down to 7 minutes 55 seconds. Cut yourself down to 7 minutes 50. Towards when you have at least 1 to 2 months before your exam, start practicing only with 1 minute 30 seconds of reading time, 7 minutes 40 seconds of presentation time. This should be the ideal when you are 1 to 2 months away from your exam. So start practicing with 8 now, no problem. Take your time because I know we are still finding our ways. We are still figuring out on the structure. We are still figuring out on content. So no problem. But towards the exam, you need to cut down everything. All right, now down to resources. Right, my most favorite golden resource is the handbook. Please, please, please read the handbook. I love the handbook. I hope you also love the handbook. Watch the YouTube video if you don't know how to use the handbook. And I know it's a bit difficult. Many people don't use it. But one thing to take note when using the handbook is that guidelines have changed a little bit. So only when it comes to management part of things, refer to RCH, refer to online, refer to health pathways. Otherwise, should not be too much of a problem. Everything else should be the same. What they require of you within the history and the story will be the same. And a lot of times candidates are practicing using recalls. It doesn't make sense to practice using recalls because you don't even have the complete story when you do those, right? But when you do the handbook, you actually know what exactly are you supposed to ask, or what exactly are you supposed to say. So let me just very quickly bring you to the handbook a little bit. Okay, I hope I have it open. Okay, so for example, I think, okay, let's take this case for example, yeah? It's a tremor case. See, this book even tells you what exactly you are supposed to tell your patient. I mean, the role player, the doctor, sorry. So please follow this book as close as possible. It will help the role player be a good role player. You will understand how to use this book a little bit better if you spend time reading. And please do not stress on doing all the cases. Every day, if you can do 1-1, 2-2 with your buddy, more than enough. So try to use the handbook as the basis to practice your role play, not the recalls. Recalls makes you a little bit more recall bias. It gives you premature closure. You force fit an answer from the patient. So I would like to give a few examples. A lot of times when I do cases with you guys see the stem, you guys already fix a diagnosis in your head. And then now you are forcing me to tell you the diagnosis when what I have in mind or what the structure is or what the diagnosis is entirely different from what you have in your head. But you are forcing me to give you what you assume it to be, right? So please make sure you're not recall biased in your stations. The minute you're recall biased, examiners will sniff you out in your station. Very, very easy to catch you. And if you go further in this book, they will tell you what the expectations of you are in this case. All right, they will tell you expectations. They will also give you what are the key issues, what are the key problems that people have in this case, and what your diagnosis must include, should not include, and how you're supposed to think. So please spend time and sit with this book for a while. It gives you critical errors. It also gives you commentary. Well, some of you guys might be tired to read the commentary. It's okay. I can close one eye, but at least do all the way up till here. Okay, do up till here, you're good enough. Okay, if you can push a little bit further, of course, you do the commentary. Wow, amazing and wonderful. And if you do note, when you start reading more of these commentaries, you will realize that they'll tell you a good candidate does this. An excellent candidate will does this. So now you know how is the scoring changing between someone who's just average, someone who's better than average. And our goal is to be better than average. So even if we fall short a little bit, we know that we are still standing at 4 and 5. We're not falling down to a 3 in our global rating scoring. So that's the goal when you're doing the AMC exam. Now, so this is the best one to use. Of course, the other one is, this is an example of how it looks like. I think I brought you guys the book. All of that, okay? This is just for you guys to read. I've done this case before. Now, I have posted this in one of the groups. I will post it again. I think I've also uploaded it on the Google Drive. Here, I have done a couple of cases where I've done the cases, I put the critical errors, and then I've also put in the key points that you need for this case. So please refer to them. These are the common, I think I've done for 60 cases or 40 cases, I can't remember. Please add on. And the reason why I didn't share the file that I did everything was because I wanted you guys to also do your part in learning. Because if I give you everything, it's very difficult. Your brain won't remember. Your brain will remember yourself putting the effort. It will remember you flipping the book. And remember you learning from that. It won't really remember me telling you. Which is why, so, and also when you're studying for the exam, please identify what kind of a learner are you? Are you a kinetic learner? Are you a visual learner? Are you a learner who uses colors to learn? Identify all of this before you sit for the exam and see what works best for you. Okay. Now, this is the other one. I think most of us might have used this for AMC 1. If you haven't, well, let me just remind you, it's a colorful book. It has colors inside. There's a lot of things inside. Well, I think most of you guys would have heard, John Mutak has passed on recently. So he's one of the very, very highly respected GPs that we all had in Australia. He really gave a lot to the healthcare system and to students and to IMGs especially as well. So he was also part of AMC. He was an examiner quite a couple of times until he turned a little bit old. So fantastic. I think it's a good memoir for him as well. So please read this book. If you cannot read this completely, refer to this. The reason why you need to refer to this is because it very quickly gives you the investigations that you need. It gives you triads. It also gives you other kinds of key points and differentials that you need and causes. So as you're reading this book, you can help to structure and make your history taking a little bit more organized. And like, oh, I missed asking this question in my structure. How do I put this in? How am I going to confirm my patient has this problem? So please refer to this book as and when you need it. I did not use I used John Mutak, my AMC one, very, very, very heavily. AMC 2, I use it as a reference point in case I forgot something or I didn't know was something included or not included. I always came back to it. Of course, supplement this with your guidelines. The new one he did is quite fresh, but still always check your up-to-date guidelines. Now, before I end up, oh yes, Telly O'Connor. This is for physical examination. Now, Telly O'Connor is written by your Australian doctors as well, so it's up to Australian standard. It has images, it has very nice explanatory of how things are. It also, the other version people can use for physical examination is Geeky Medics. But the problem with Geeky Medics is that, I mean, it's fantastic, okay? The accuracy is fantastic, the procedure is fantastic, structure is fantastic. But the only thing that Geeky Medics doesn't teach you very much is how to do the switch between role player to your examiner. Okay, it doesn't quite teach you that switch. So once you learn how to do the physical examination, you still need to come back to yourself. You still need to consolidate on how you would do the switching, on how would you speak to examiner and and talk to the role player and give your commentary at the same time. That only comes with practice and with time management. So PE a little bit more tricky if they specifically ask you for commentary and give you marks for that. Otherwise, physical examination is not very difficult. Try to read one or two, and every time you do a case, for example, let's say you do headache in the morning. Now, in the evening, if you're revising, just very quickly do physical examination for headache. So make your learning together. Don't just always focus on one particular thing. And you need to understand, in the exam, every room you enter is a different core subject. Right? You're going to go from med-surg to OBG to PEDS to PE to psych to OBG again. So it's going to be crazy in the exam. However, now if you train your brain to only do med-surg for 1 month, then you do OBG for 1 month, then you do PEDS for 1 month, your brain is so used to only seeing the same thing every single day. Your brain gets used to familiarity. When the anxiety comes in during the exam, the brain gets very confused. So you're not only handling your own anxiety, you're also handling your confusion of the brain in the exam. So what my suggestion is that, yes, maybe the first 1 month you can do very cluster-based core subject studying, but towards the exam, when you start practicing cases properly, you need to start practicing different cases and different chapters and different core subjects. That is the only way to reduce your anxiety. The thing is, when you go for the exam, 110% you are going to be anxious. There's no doubts about it. Your job now is to not only strengthen yourself clinically, but be like, how can I reduce my anxiety? How am I going to be flexible during the exam to work on my anxiety so that it doesn't restrain me from giving my best. I always can give my best even when I feel anxious. That is the thought process behind this exam. All right. Now I'm going to show you a little bit more about the exam on the structure of the day so you're aware of what goes on. So on the exam day itself, you have registration, you have waiting area, and you have I can't see the slides. Give me a second. You have the, what is this? Oh, the exam itself. Yeah. So please bring 2 identifiers. For those of you who are from India, I know that visa is a very, very big problem. Please, the minute you've gotten your date, please start applying for your visa. Don't wait, because I have a lot of doctors who have been rejected before. So please work on that very well. During the exam itself, you can bring your own stethoscope, but they also provide you one there. If you want to feel a little bit more confident, I always say put your steth around your neck, even when you are practicing with your role play partners. You need to start feeling and have your experience as close as possible to the real exam. I also told you guys, for physical examination stations, please use gloves when you are practicing. Sanitize your hands. Get a sanitizer. Sanitize your hands. Wear your gloves, and then you practice. A lot of you guys have been asking me, Love, can I put gloves and then sanitize my hands? The answer is no. The examiners know that we are doing that. Therefore, they have stopped you from doing that. You are required to put your sanitizer first and then wear your gloves. The other question I get is, oh, Love, can I use the big sanitizer? I mean, the big glove size. No. They look at your hand size. They're like, oh, you look like an M. Take an M. Oh, you look like a letter S. Take letter S. So you are not really allowed, or able to rather, go for the big glove size. So please practice wearing gloves. They use the normal blue color gloves, guys. Not very fancy, just a normal blue color one. And the problem with the gloves is this, right? For those of you who are doing surgery, in surgery, it's very fun because when you go in, your gloves are already open. You just have to put in and then flip it over. Right? However, in the AMC exam, it's literally that tissue box, that entire box of gloves, everything put inside. So which means when you take out a glove, it's going to be super crumpled. So make sure you shake it off, make sure you open it, and then you put it in. Please don't blow into it. It's not sterile anymore once you blow into it. I know maybe when you are working, you do that. You just poof, and then you quickly wear your gloves. But in the exam, please don't do that. Okay, just take the gloves, shake it up a little bit, loosen it, and then you start wearing it. That's one more thing to take note. Otherwise, before the exam, I think before I started, I did speak a little bit about having your good sugar food, but not high sugar, so you don't have a sugar crash in your exam. And depending if you're morning's the exam or afternoon exam, a little bit more different. So for morning exam doctors, your waiting time is very, very less. So once the 20 candidates are in the waiting area, your exam starts. You go in, you start your exam. However, for the afternoon exam candidates, they wait for all the 20 of you to go into the waiting area. They then release the morning candidates. So there's no crossover between the two of you. And then once the morning candidates leave, your examiners go for a very, very, very short lunch break. The role players go for a very short lunch break. And then your exam starts thereafter. Okay, then after your exam starts. And then, so it takes about at least 1 hour from the time you actually check in, or even 1 hour, 10 minutes before you start your exam. So anxiety will start to peak for afternoon people. Now, if you are pregnant, please be careful of your morning sickness. Please bring sweets with you. You're not allowed to bring sweets into the exam area, but you can put your sweets in your locker. So during your rest stations, you can come out and you can take your sweets. You only have 8 minutes to do that. And the resting area and the locker area and your exam area is very near, so not to worry too much about it. And of course, toilet only 1 by 1 at every time once the exam starts. And I think I want to discuss about 2 minutes reading time and 8 minutes presentation time. So I think I have a little slide on how the exam looks like. Okay. So there'll be 10 rooms on one side and 10 rooms on the other side. You would always be moving towards your right-hand side. Is left. And you're always moving towards your right-hand side. So everyone will be having your starting station written on your lanyard. You will start from there. Station number 3, station number 8, 13, and 18 are your rest stations, which means if you start from station number 3, you got nothing to do in the first station. You relax for 10 minutes of your life, right? And then once you have a back power of 4 stations to fight through. So I always told you guys, if you are doing any back-to-back practice with your role play partners, towards the exam especially, do 4 stations back-to-back, because the maximum number of stations you will do is 4. You need to have minimally have enough stamina to be like, can I think at the same power as station number 1 versus station number 4? And when you go for trial exams, don't have to do too many trial exams, guys. Just 1 or 2 is more than enough. But you must understand, what is the purpose of me going for a trial exam? Am I going to see my standard? Or am I going to expose myself to many, many questions? Or am I going to see do I have enough stamina to sit from station number 1 to station number 20? So you need to know your purpose for doing the trial exam. Because I sometimes have a lot of doctors coming in and I'm like, so why do you want to do the trial exam? Oh, I just want to do because I feel like I should do. So please know your why. Okay, don't forget your purpose behind things, right? So from your starting station, you'll be here. Everybody will be queued up in the first station. You'll be given 2 minutes. You only get 2 minutes in your first station. The reason is because once you go into the room, right? Your 2 minutes finishes, you go into the room, your 8 minutes starts, right? But let's say once the 8-minute bell rings, the 2-minute bell for the next station or 2-minute timer is already ticking. However, you will still be inside your room, right? Thank you, examiner. Thank you, role player, pushing my chair. And then you walk out of your room. You come in front of room number 2. Here, you are given another 2 minutes. But by the time you come here, it's already 1 minute 20 seconds, 1 minute 30 seconds. So you will never get the full time to read your STEM after station number 1. And let's not forget, when you're going further into your stations, your brain will be like, what did I miss in that station? I'm very sad. Well, to be very honest with you, in one of my stations, my eyes were so teary. I cried in one of my stations in the exam because I panicked a little bit. I think it was my second station, right? Thank God my third station was a rest station. But then my eyes were still teary when I went to station number 4. So I started from station number 1 in my exam, my real exam. So I failed station number 1 and 2 because it was a mess. Okay, after station number 3, I rested a bit. I managed to pull myself back and then I managed to pass the rest of them after that. But it was a bit traumatic of an experience. So when I came to station number 4, my eyes were still wet and teary. So I could not see the STEM. So I'm there busy wiping my eyes and trying to read the STEM. So these things will happen in the exam. I also have seen doctors who blank out. So they are looking, but then you blank out. You're not thinking, right? Because you just zone out. It's just a moment of anxiety or brain block. So all this will happen, which is why I tell you, please practice with 1 minute 30 seconds towards the end of your exam. And now, writing materials, Dr. Basil, you're not allowed to write in the 2 minutes. So in the 2 minutes, you are standing outside. Okay, you are standing, you have a mini computer in front of you, and it is very, very dimly lit. So I'll usually put my face really, really near to it. And then you have no writing. But once you go into the exam room, you have writing material. So I'll show that a little bit, okay? Okay, this is how the exam room looks like. But please don't worry. Once you enter the exam room, the screen will have a STEM and a task. Okay, you also have a printed task and you also have a clipboard with paper and pen on your table. This is how your exam room will look like. So here I have the door, right? The triangle is the door. Now there's 2 X's here. The reason why I put 2 X's is because these are the 2 locations where your sanitizers are. You are required to sanitize in every single station, not just your physical examination. I know it's very annoying. Okay. I struggled with that as well because I did not practice with that until one of my friends told me about it. And she said for the exam like a week before mine, right? So every station you're required to sanitize your hands. Depends on where the sanitizer is. And the sanitizer that they're using is an automated sanitizer. So I remember there was a point in time I wanted to be a genius after station number 3. I was like, oh, I'm going to show my tag to the examiner and then I'm going to sanitize my hands. But I forgot it was an automated sanitizer. So the longer you leave your hand under that machine, the more balls of foam is pouring into your hand. And that is terrible because now you have a sanitizer to wipe. You have so much of excess. I just wiped it on myself because I had no clue where to wipe these things on. But there was a tissue paper there, but my brains didn't work. So my first 10 or 8 stations, I did not use tissue paper. But I remember that once I got a grip of myself towards the last 10 stations, I used tissue paper to wipe my hands. And I also wore dark blue pens. So I wiped it on my pants. It was not visible at all. And I also had bare below elbow, which means I didn't wear long complete sleeves. I only wore up to my elbow sleeves. So I could still wipe it on my hands a little bit. Okay, so that's one thing to remember in the exam as well. And once you go into the exam, you would see the role player, you and the examiner. Examiner will always be behind you, and the chair is a rolly chair, the one that you can turn left and right. So if your task says, tell the examiner, ask from examiner, please roll your chair, not roll your chair, turn your chair and look at the examiner and then go, examiner, can I know, and then ask the examiner. Once you're done, thank you, examiner, roll your chair back and then face the role player and talk to them again. So these things all require practice. The more you practice with all of this, the sharper and better and more flexible you'll become. Because I think a lot of times candidates don't do well, not because they don't know what to do. It's because they get thrown off by all of these things that people don't tell them about in the exam. But the more you prepare yourselves for these things, the easier it will become to handle. And yes, the screen is very, very big, guys. I think it's like a 40-inch or more than a 40-inch TV that's there. That TV screen has the entire STEM and the entire task written to you. On your table, you also have a pen. You also have a paper. So which means 360 degrees, basically, you have view of the STEM with you all the time. So you wouldn't always be on task. So don't worry too much about it. Any questions from today? Any questions? Yeah, someone asked me for my YouTube channel, right? I will show the screenshot in a bit. And today's video as well will be uploaded back on YouTube. But any questions about the exam, any questions? Well, the one more thing I want to tell for those of you guys who are new, I would say start preparing your differential list. Okay, prepare a paper or set of notes that 1 or 2 weeks before exam, you have something to refer to. You cannot afford to panic 1 to 2 weeks before the exam, right? So quickly just prepare this now so that 1 to 2 weeks before you are just referring. You're not creating notes from scratch. Okay. And now, well, it is better. I've always wondered about this, but my answer is it's better to read the STEM. Read the STEM first and read the task. The reason is because you already know that the task is quite limited, right? The basic structure of your task will still be roughly be history, roughly be PP, roughly be management, maybe management a little bit more complicated. But then if you don't read the STEM, you won't be able to handle anything. Knowing the task won't really help you as much. Task you can still read last minute and figure it out. But if you don't even know what the STEM is about, it's very hard for you, even if you know what the tasks are. So read the STEM first, and then you read the task. So at least you're really starting to structure in your head. Then when you read the task, you are rearranging the structure and editing the way you're going to approach the case. But of course, see what works for you though. For me, that's what I tried both of it. And I was like, every time I read the task, I spend too much time reading the task. I was like, I'm spending so much time trying to understand, trying to see, oh, is there anything that I'm missing out? I tried to go and nitpick the task and it didn't help with me because now I didn't have enough time to read the STEM. So now when I go into my station, I have no clue what I'm doing. So read the STEM first, know what your station is about, then do the task after that. Any other questions? And for, of course, what is the meaning of choice of physical examination? Well, I believe this one comes under physical examination from examiner, and of course, choices as well. There are many times candidates actually do irrelevant physical examination. So, for example, in a patient who comes to you with, let's say, chest pain, right? Someone comes to you with chest pain. You're supposed to technically do a hemodynamic stability right on top. You do general appearance, you do vital signs, you do BMI if needed. You're supposed to do cardiovascular first. But I have worked with doctors and seen doctors out of nowhere, suddenly, because they go like, oh, it might be a heart failure case. There's ascites, right? They immediately spend their time doing abdomen. They get distracted. They go and do abdomen first but I know why they did abdomen first, because they want to go do their hepatojugular reflux. They want to go and do their ascites. I really understand why. But the thing is, that gives you an irrelevancy of that. You're supposed to do cardiovascular first. So don't get distracted by the story that you are getting in your exam. Always go back to history of presenting complaint. Any other questions? Any other questions? If not, yes. I will stop share for a bit. Okay, I will stop, not stop share. I will stop the recording for a bit.